In this video, I would like to go over the mechanism and the application of the anticoagulation, antiplatelet, and thrombolytic drugs. But before doing that, I would like to first go over the mechanism of hemostasis, and then after that, it would be easy to discuss the application of every drug. So here, if we have the vascular endothelial cells, once there is a damage to the vessels, collagen would be exposed. And then von Willebrand factor binds to the collagen, and from there on, the GP1B receptor of the platelet will bind to the von Willebrand factor. From there on, there would be release of the granules, which will contain the ADP. ADP acts on the ADP receptor that causes conformational changes, as a consequence of which another receptor called GP2B3A would be exposed to the cell surface. And this GP2B3A would be able to bind different platelets to each other via the fibrinogen in between. So here we have the fibrinogen, which will be able to bind the platelets to each other via the GP2B3A receptor. So this whole mechanism is referred to as primary hemostasis. So once these platelets are adhesed together, next they would have to be stabilized, and that would be done by the formation of a fibrin mesh. So here is the coagulation cascade, also known as secondary hemostasis. And there are intrinsic and extrinsic pathways. So the extrinsic pathway can be monitored via the activity of the prothrombin time. And then the way I memorize it is that E goes for PET. So extrinsic pathway via the prothrombin time. And then the partial thromboblastin time is being used to monitor the intrinsic pathway. And again, the way I memorize it is that PET, so for PTT, for the intrinsic pathway. So the intrinsic pathway functions via the factor 12, 11, 9, and 8, while the extrinsic pathway functions via factor 7. So once there is a damage to the vessels, it would cause the exposure of the tissue factor, which will activate factor 7, and it will eventually lead to the activation of the thrombin. And thrombin causes conversion of the fibrinogen, or factor 1, into fibrin. In addition, thrombin acts on factor 13, and factor 13 will convert the fibrin monomers into fibrin polymers, or fibrin mesh. And this will stabilize the blood clot. So this whole mechanism is referred to as secondary hemostasis. So now that we've discussed the mechanism of hemostasis, next I would like to go over the mechanism of function of different anticoagulant drugs. So here for anticoagulation, I've divided them into two categories. One is the parenteral, so you will have to administer them either subcutaneous or intravenous or via other routes. And then we have other ones that are via the oral route, like warfarin. So heparin includes the unfractioned heparin, as well as low molecular weight heparin. And then low molecular weight heparin, an example of it would be the enoxaparin. So how these medications work is that they act as antithrombin 3, which will preferentially inhibit factor 2A and factor 10A. And then you can monitor the activity of these medications by checking the PTT. Now, heparin is generally used for quick anticoagulation, so it's used for the DVT and pulmonary embolism, or for acute setting like once someone has an atrial fibrillation. While for chronic settings, you would be using the warfarin for long-term treatment. Now, if someone develops bleeding from too much heparin and you check and you see that the PTT is too high in these patients, then what you can do is that you can give them protamine to reverse the effects of the heparin. But note that the low molecular weight heparin is not very responsive to the protamine. So it's only the unfractioned heparin that will respond well to the protamine to reverse the effects. Now there is one other findings that may develop in these patients, and it's called the heparin-induced thrombocytopenia. And in this condition, there is the IgG antibodies that are formed against platelet factor 4. So there would be destruction of platelets in these patients, and they would start to develop bleeding. So if that happens, right away you will have to stop the administration of heparin, and you will have to supply these patients with either lepyridine, which is a factor 2A inhibitor, or you can supply them with the argatroban, which is another factor 2A inhibitor. So this is argatroban, which is a factor 2A inhibitor, and it can be provided orally, or you can provide them with the lepyridine, which is another factor 2A inhibitor, except that it's being provided via the parenteral route. Now, the mnemonic that I use to remember what medications are used for the treatment of the heparin-induced thrombocytopenia is called the arrogant leopard. So you can provide these patients with lepyridine, or you can provide them with the argatroban, which is both of them are factor 2A inhibitor. The next medication is the fondaparinux, which is a factor 10A inhibitor, and this is supplied via routes other than the oral route. But then there are also medications, factor 10 inhibitors like rivaroxaban, which can be administered via the oral route, and then it still inhibits factor 10A. And then another important medication, as I just discussed, is warfarin, which is used for the chronic anticoagulation. And how it works is that it's a vitamin K antagonist, because it has a similar structure to vitamin K. And vitamin K is required for the gamma carboxylation of factor 2, 7, 9, 10, as well as protein C and S. So by inhibiting the carboxylation of these coagulation factors, you will cause anticoagulation in these patients. But note that protein C and S are anticoagulation factors. So by inhibiting protein C and S, initially there would be increased risk of coagulation in these patients, and they may develop gangrene and skin necrosis. That's why you cannot right away give warfarin to any patient. So first you will have to start warfarin along with heparin to decrease the risk of coagulation. Once the warfarin reaches INR level of 2 to 3, then that's the time that you can start heparin and then continue warfarin. But you will have to make sure that the INR stays between this range of 2 and 3. And then you may ask, what is INR? So you know how PT is used to check for the extrinsic pathway. Now, if you divide the PT of your patient to PT of a control individual, then this ratio is referred to as INR, or international normalized ratio, and your goal is 2 to 3 for warfarin therapy in these patients. And then the application of warfarin is usually for the treatment of DVT, pulmonary embolism, atrial fibrillation, as well as cardiac aneurysms. So if someone is at increased risk of DVT, PE, and AFib in an acute setting, you were giving them heparin. But once you discharge them home and you just want to make sure they don't develop any of these conditions in the next months, then you can provide them with warfarin. But first you will have to make sure that you will bridge it with heparin until INR reaches a level of 2 to 3, and then by then, when you know that there is no risk of hypercoagulation, then you can stop the heparin. Now you should also know that warfarin is a teratogen, and thus you cannot supply it in patients that are pregnant. So heparin can be used for anticoagulation in pregnant patients, but not warfarin, because it's a teratogen. And then you can reverse the effects of the warfarin by providing either vitamin K or by providing the fresh frozen plasma in these patients. Now the next classes of medications are antiplatelets, and the first one is the aspirin. So aspirin functions by inhibiting the cyclooxygenase enzyme, and the cyclooxygenase enzyme, once you inhibit that, then there would be decreased production of the prostacyclin, while there is also decreased production of thromboxane A2. So thromboxane A2 will decrease blood flow while increasing the platelet aggregation. So once you inhibit that, then there is decreased platelet aggregation. But prostacyclin, on the other hand, has reverse effects. It increases blood flow while it decreases platelet aggregation. So then if aspirin is causing inhibition of prostacyclin, then why is it that we are using it for anticoagulation? And the reason for that is that thromboxane A2 is inhibited in platelets, and platelets cannot make new cyclooxygenase, so therefore there would be decreased platelet aggregations. Prostacyclin, on the other hand, is being produced by the endothelial cells. Once you block them with low-dose aspirin, endothelial cells can start to regenerate COX again and make more prostacyclin. So therefore, that's the reason that we can use aspirin for anticoagulation, because prostacyclin will be remade by the endothelial cells, while thromboxane A2 cannot be made for the platelets, as a consequence of which there would be decreased platelet aggregation. Now, the side effects of the aspirin include the gastric ulcer. So since the aspirin inhibits the production of the prostaglandin, then there would be increased risk of gastric ulcer. There's also risk of tinnitus. And then finally, if you give aspirin to young individuals, they can develop Reyes syndrome. So children that have viral infections, if their parents start treating them with aspirin for their fever, they will develop hepatoencephalopathy, and this is referred to as Reyes syndrome. So you would never supply aspirin in these patients unless they have the Kawasaki syndrome. So the only indication for the use of aspirin in children is Kawasaki syndrome. Otherwise, you won't use it because it can cause Reyes syndrome. And Reyes syndrome presents with the mitochondrial abnormalities, fatty liver, hypoglycemia, and coma. So because of that, they present with liver and brain abnormalities. The next classes of medications are phosphodiesterase enzyme inhibitors like dipyridamole as well as the silastazole, and these medications, as I mentioned, are phosphodiesterase inhibitors, as a consequence of which there would be increased concentration of cyclic AMP and cyclic GMP, which will cause vasodilation and decrease platelet aggregation. So generally, these medications are used in patients that have claudications. For instance, if they have claudication of legs, then you can use these medications for them. The next classes of medications, clopidogrel, ticlopidine, and prasugrel, these are acting by blocking the ADP receptor on platelets. And if you recall, ADP receptors, they were required for changing conformation of the platelets so that GP2B and 3A receptors would become exposed, they bind fibrinogen, and then platelets can be able to adhere together. So by inhibiting the ADP receptors, platelets can no longer come together. And generally, these medications are used in patients that have a coronary stent. So if there is a patient that requires, for instance, a stent placement in their coronary artery, then you would put them on these medications for 1 year to prevent clotting of the stents. And then one important side effect that you have to be familiar with is that ticlopidine causes neutropenia. The next classes of medications like abciximab, tirofiban, as well as eptifibatide, these are directly binding to the GP2B3A receptors, as a consequence of which they would prevent the binding of the platelets. And this is usually used in patients that require angioplasty. And then finally, we have the alteplase, which acts on the tissue plasminogen activator to convert the plasminogen into plasmin. And plasmin has two main functions. One, it will induce the breakdown of fibrin, and two, it will cause the lysis of thrombi. And thus, by doing these, there would be an increased PT and PTT on lab findings. And then the applications of alteplase include for the ischemic stroke, for ST segment elevation myocardial infarction, or in patients with pulmonary embolism or deep venous thrombosis. Now, in a patient that has sign of stroke, in order to differentiate ischemic from hemorrhagic stroke, first you will have to obtain a CT or MRI in these patients to rule out hemorrhage. And so once you confirm that it's an ischemic stroke, if the onset of symptoms is within 0 to 3 hours, or in some specialized centers up to 4.5 hours, then you can continue with the application of alteplase. But if you pass the 4.5 hours window, then you would no longer be able to give thrombolytics in these patients. And in patients with ST segment elevation myocardial infarction, your window is 12 hours. So just keep that in mind. The window time that you have to give alteplase in patients with ischemic stroke is 0 to 3 hours, and some specialized centers you can stretch it up to 4.5 hours. Once you pass 4.5 hours since the onset of symptoms, you can no longer give alteplase. And then for ST segment elevation myocardial infarction, your window is 12 hours. Now, if you give too much alteplase and there is bleeding in the patient, then you can reverse the effects by giving aminocaproic acid to these patients. So aminocaproic acid will reverse the effect of the thrombolytic medications. And that concludes our discussion.